Let me start our case discussion number 1 today, presented by Miss Esmas Mano. She is from breast endocrine training from IIUM. I will invite Prof. Shahrun and also the fellow trainees to the stage to be together with Miss Esmas during this presentation.
Okay, Assalamualaikum warahmatullahi wabarakatuh and very good afternoon. Yeah. Okay, so today I would like to present a case discussion from
Before that, can I have the trainees to be on the backstage?
from HKM. Hello.
Okay, can continue. You can continue now, Esmas. Hello, Esmas, boleh start?
Esmas, you can start.
Can start now?
Esmas, you can start. Esmas, you can start your slide. Esmas, please share your slide.
Belum start. Okey. Kalau dah start bagi tahu.
I think you can start now.
Okay, since Miss Esmas having problem with her computer, we move to Mr. Amin from Hospital Putrajaya. Amin, please.
Okay, Assalamualaikum and very good morning to dear consultant, my fellow colleagues and all the audience. So today we'll discuss on one case on adrenal. Okay, this is Madam CCS, an ex-staff nurse from Malacca. She is a 61-year-old Chinese lady with background history of a bilateral tubal ligation about 25 years ago. Presented with complaint of persistent right flank pain for 3 days. Prior to that, had a history of slip and fall 1 week prior to current presentation, where she sustained right second and fourth metatarsal cross fracture, which were treated conservatively. Otherwise, there's no other injury reported. Due to new presenting complaint, she sought consultation at private hospital in Malacca. Proceeded due to a history of recent slip and fall. So the private hospital in Malacca proceeded with CT thorax, abdomen, and pelvis, which revealed finding of huge right adrenal mass, measuring about 8 by 3.7 by 6 times 2 centimeters. So she was then referred to HPD for further evaluation. Okay, how would you approach when you receive a referral with this kind of presentation, when patients came with discomfort and finding of huge adrenal mass?
Okay, Miss Tan, can you answer the question?
Good morning, Prof. Shaun.
Yep.
This is a lady that presented with the right adrenal mass. I would like to know if the mass is of any functionality or is it of malignancy. So first and foremost, I would like to know if she has a background of any hypertension that could indicate this is a functioning mass. And then I had a brief glance at the CT just now, but it looked like a large mass.
I will show
So
the CT later, the full
okay.
CT later.
So the another differential diagnosis is if this is of malignant ACC in view of its size. So I will proceed then to refer the case to co-manage with the endocrinologist for functionality workup.
So for what do you think the functionality workup would be?
We will have to take the serum aldosterone, 24-hour urine catecholamines, and looking at her baseline renal profile will probably give us any clue of any electrolytes abnormality. And we will and serum cortisol. Yeah.
All right.
Okay. So as usual, how we would approach, definitely we will go back again because we have a just brief history from the referral center. So we go back to the clinical history, further clinical history, and to examine patient. So she was a previously well lady, no history of paroxysm, deny any palpitation, any headache, any excessive sweating that could lead to symptom of pheochromocytoma. Also deny any constitution symptoms, no family history of malignancy. So on examination, she is a small built lady, not cachexic, no features of Cushing, no evidence of viralization, patient otherwise normotensive and not tachycardic. Physical examination revealed no evidence of palpable abdominal mass and other systems are remarkable. So as Tan mentioned earlier, she had done a basic blood investigation in the private center, of which everything almost normal except for slightly raised in the CRP. You can see the potassium also normal. So when we have this adrenal lesion, so as Tan mentioned earlier on, so proceeded with the functional workup. And surprisingly,
what is the calcium level?
Calcium level, I don't have here, but the calcium is normal, Prof.
Okay.
Okay. Functional workup done to exclude PO, to exclude functioning of any functioning secreting tumor, everything came back as normal, including the DHEA. So next, I will show the CT scan. So please pay attention. I will, because the play is too fast, so I just move the cursor so you guys can focus. So this is one of the, this is a photovenous CT, because this is the I think the clearer that I can see. Please pay attention to right and left. Okay, anyone want to comment on the CT finding?
Can I have hi? Hi ada? Okay, ada hi. Azlinda? Dr. Azlinda ada?
As Linda is loading, why not we call Nadia?
Thank you, John. This is the contrast enhancity of the abdomen. There is actually, boleh go back to the huge right.
Okay, I'll show you.
There is actually heterogeneous right suprarenal lesion, which is actually, there is area of calcification within, and probably there is area of hypodensity, may represent necrosis, but there is actually, I can't see exactly the right renal vein involvement, but it seems like the IVC is at least, there is a butting. There's no obvious encasement of the IVC, and the plane to the liver is also not really nice. But looking at the left lesion, there is actually the left adrenal is also slightly enlarged to me.
Nadia, when you talk
Yeah.
about relation to the liver, you mentioned about not really nice. What does it mean, not really nice?
The margin of the heterogeneous right suprarenal lesion is not well circumscribed regular, because it looks like the plane to the, it abutting, at least it is abutting the liver and also the IVC.
Yeah,
in my
but actually,
opinion.
there is a plan, because I think my quality is quite poor. So, but there is a plan between the liver and the IVC.
Okay.
All right.
But I would like to know the Hounsfield unit of this lesion, and also the washout, the absolute washout, the relative washout, if I can get that information.
Okay, so the CT earlier on shot, okay, you can see huge, well circumscribed tumor with the no invasion to the surrounding structure. And the left, as Ms. Nadia mentioned, there is a nodule at the body, so measuring about 1 by 1 by 3 centimeters. So for the right side, the Hounsfield unit on the unenhanced CT is 39, and the absolute contrast washout was 31%. And the left side is consistent finding with adenoma. So now we have this right side, this huge mass, and we've already done the functionality test to see, and it come back as non-functioning, and CT shot as such, where the Hounsfield unit is 39 and absolute washout 31%. So we can conclude this is a non-functioning large right adrenal mass with possible malignant because of the characteristic from the CT scan. So what is the possible differential diagnosis at this juncture?
Can I have Dr. Lee Chang Hao? Dr. Lee? What is the possible differential diagnosis?
Lee, can you switch on your microphone, please?
Can you hear me, Prof?
Yeah, okay.
Yeah, sorry about that. Seeing as it's non-functional, I would think along the lines of adrenal lymphoma. Things would it's quite large, so an adenoma is also possible, but would be lower along the lines. I wasn't sure whether there were any lesions elsewhere that could not be seen in the lungs or in other solid organs. So we still have to think about cortical carcinoma.
Okay.
Probably some less likely differentials. Metastasis to the adrenal, probably from some other primary. Lymphoma, sarcoma, unlikely. Yeah, so non-functional, I think, can be quite a lot of differentials, bro.
All right.
Okay, thanks, Lee. So as you mentioned earlier on, based on the characteristics from the CT finding, it's unlikely it's an adenoma because this is not lipid rich. So based on the size as well. So in literature,
Amin, sorry, Amin. There is a question from the audience.
Oh, sorry.
Is the one that the hyperdense, is it calcification ke bleeding?
No, it's not calcification. Actually, this is because this when you read it from the plan, the contrast, this is just a mild enhancement of the contrast and delay washout. So this is a contrast actually in the photoabdominal vest. This is calcification or bleeding.
Okay.
Okay. So as Lee mentioned, so large adrenal tumors, some literature said more than 5 centimeters. Of course, we're thinking of the adrenocortical carcinoma. It still can be malignancy, but functional study revealed is non-functioning tumor. It could be secondary metastasis, but then the CT-TAP initially didn't show any evidence of any primary elsewhere from the thorax down to the abdomen. In the list, we could think still lymphoma, but then it's very rare. Patient don't have any B symptoms. Patient don't have any lymph adenopathy to start with. Okay, what's next?
Can it be a total of benign lesion? That huge can be a benign lesion.
Possible. It's still
and what
possible.
would be your possibility of a huge benign adrenal?
It still could be angiomyolipoma of the adrenal.
Okay. And before that, I just want to ask, why is this patient presented is asymptomatic and she fractured, she fell and she fractured her legs?
Betul.
What makes you do a CT scan of the abdomen?
Okay, this patient was referred from the private hospital. He had history of slip and fall 1 week prior the presentation. So she presented with the right flank pain. So being in the private hospital, they run the straightaway CT thorax abdomen pelvis for patient. That's when they noted this finding.
All right, fair enough.
Okay, with all these findings, so what's next? Any other investigation need to be done? We just wait and see, or offer patient for operation?
Do we have one Suriza here? No, you don't have. Miss Azia.
Yes, Prof. As a lesion is huge and causing a right flank pain, and the feature suggestive of malignant lesion because of the Hounsfield unit, I will offer patient operation.
What operation are you going to offer?
I mean, the lesion is about 8 centimeter, right?
The largest diameter is 8 centimeter.
8 centimeter. So I will offer her open adrenectomy with the anterior approach.
Okay. Any other investigation you think need to be done before proceed with operation, or just enough with all the, investigation that we've done before embarking into the operation for patient?
I mean, I don't agree with Azia. I don't agree with Azia.
Sorry, siapa ni?
Nadia.
Okay.
since you have mentioned the PET scan, even though the CT showing a suspicious lesion because of the size and also the few malignant suspicious features, but you from the CT TAP doesn't show any other source of mets to the
Primary.
adrenal. So I would still think this is a primary adrenal lesion. The another option is PET scan, but like Lee mentioned earlier on, the possibility of lymphoma, then I would go back and confirm what are the risk factor if this patient has lymphoma. And then if you are thinking down the line for lymphoma, actually there is a role of guided biopsy of the adrenal. But it must be strongly, we have to rule out it's not a primary ACC of the adrenal. Hey, Prof.
Okay. At this juncture, as I mentioned earlier on, from the clinical history, patient was previously well. No symptoms to suggest patient to have lymphoma. And then the CT finding is, like we see earlier on, solitary right huge mass with a small left adrenal adenoma.
Since Lee also mentioned lymphoma, what is the LDH level of this patient?
Yes, I will show you later.
Oh, okay.
Okay. So,
all right.
yes,
So, okay, you just continue first.
Okay. So we have the NDT discussion. So after discussion, the NDT and discussion with patient in view of the size. Also, the patient have a discomfort on the right side. And looking at the CT scan, the lesion is huge, but then it's still resectable, is well circumscribed. So we did offer patient for open right adrenectomy. However, because of patient have recent fall and fracture her right second until fourth metatarsal fracture and on POP, so she requested the operation to be delayed. So the progress, she denied any further discomfort except for the initial presentation. As an ex-staff nurse, self-conscious, so she went to private hospital and had ultrasound done to reassess whether the lesion is still the same or growing bigger or smaller. And to her surprise, the right adrenal lesion smaller in size, almost half of the initial size, 3 by 3.4 by 3.6 centimeter. So when she came back to see us, we repeat the CT adrenal protocol. So this is the CT scan, repeated CT scan after a period of 2 months.
Can we have Dr. Adi to comment about the CT scan?
First, I would like to check whether it's the same patient punya CT scan or not. If it's the same patient, then
yes.
I can see that on the contralateral side, the left suprarenal region, there's the mass that we saw previously probably has enlarged, but the lesion, suprarenal lesion on the right side has definitely reduced in size. And the mass itself appears lobulated on the left-hand side, heterogeneous, hypodense. This is a portovenous phase. There's no arterial, probably some patchy arterial enhancements. There's no calcification. So, and the right mass looks more well-defined in terms of the borders and margins. So now it seems like the left side is more worrying to me compared to the right side. But there's no other lymph nodes that I can see in the retroperitoneal space.
Okay.
So interesting.
Okay, carry on, Amin.
Repeated the Hounsfield unit, the Morse system about 3940 with the absolute contrast washout definitely less than 50. It's about 31 for both right and left adrenal. Okay, at this juncture, now from the right side, we have bilateral adrenal mass. As mentioned, we can see the right side getting smaller, the left side getting bigger. So at this juncture, what the most likely, I mean, the working diagnosis that you're thinking of at the juncture with bilateral involvement?
Can it be infective causes?
Amin?
Again?
At this junction, can you please explain to us back what is the findings of the X-ray of the left foot? Is there anything that points out toward a pathological fracture? Is there any?
No, Prof. It's a traumatic fracture. And when he come to see us, he had a repeated X-ray done with the orthopedic. There is a callus formation healing at 2 months.
All right.
The right foot. It's a traumatic fracture. It's not a pathological fracture.
Okay.
So anyone, now we have a bilateral adrenal mass and the fluctuation in the thighs.
Yeah, I mean, I would consider something like infective causes along the line because if one is bilateral and it does have some regression in terms of the right side. But I cannot explain why the left side is actually increasing size. Hi, Prof.
Oh, hi. Okay. Carry on.
Right. I mean, do we have like any other markers like CRP or ESR level to rule out like something like infective causes?
CRP and ESR level initially, as I shown earlier, is mildly elevated. It's not really high. CRP around 14, ESR around 20.
Do we have a repeat investigation or we don't have that?
Okay, I'll show you after this. What are the possible differentials? Because this is interestingly, we can see the regression of the right adrenal mass.
What infection are you referring to?
Something like a TB.
Okay.
And then one more is actually something like a fungal.
All right. Okay. Accepted.
Okay. So as Mr. Hai mentioned, we did again discussion with the endocrine team. So there's few possibility for the bilateral adrenal mass. As mentioned earlier on, the adrenal cortical carcinoma still possible, secondaries, but then all the tumor markers done negative. And infection, like Mr. Hai mentioned, we did run for the fungal and also TB, which revealed a negative result. And interestingly, when we said the LDH is slightly high. It's 558. Okay. So at this juncture, so I just proceed, Prof. So we have a MDT discussion with patient. After further discussion and all the workup done, patient have no symptom. She refused for any surgical intervention and opted for the to observe and follow up. But then 3 months later in the line, she developed sudden onset recurrent severe right flank pain and had a repeated CT abdomen done. So this is the CT abdomen. As you can see, the right side getting more bigger actually.
Okay, I found it.
Okay, what do you think most likely favorable diagnosis for this patient at this juncture? Okay, this is actually we're thinking of because of the LDH high and bilaterality, so we're thinking of lymphoma. After discussion with patient, she agreed with tissue biopsy, went for endoscopic ultrasound guided find of the left adrenal in HKL done by the gastroenterologist team, and HPE came back as diffuse large B-cell lymphoma. Referred to hematologist in Malacca for definitive treatment. However, she refused chemotherapy and lost to follow-up. So I just want to see show the serial CT done for her and the evolving size of the adrenal lesion. So this patient actually have a large B-cell lymphoma of adrenal.
But why does the lesion get smaller along the way?
Yep, that's also puzzling us actually. Prof, I just show a bit on the primary adrenal lymphoma. Boleh, Prof?
Yeah. Did she take any traditional ubat ke?
She denied, Prof. In between, she denied taking any traditional medication or any over-the-counter medication.
Ada ambil ivermectin ke?
Tak ada. So a touch bit on adrenal lymphoma is very rare. So far in the literature, it's less than 200 cases reviewed. Of all large adrenal tumor, it's accounted for 1.2%, and for the non-Hodgkin, it's only less than 0.2 for primary adrenal lymphoma. So mean age at 62 years old, with male to female ratio almost the same. Bilaterally common, you can see is up to 70% reported cases. And common subtype, if it's a lymphoma, is a diffuse large B-cell lymphoma, up to 78%. Characteristic is very difficult because it's non-specific with heterogeneous variable density and mild to moderate enhancement post-injection. So this leads to difficulty in making the possible diagnosis. I read out few literature. The reason for fluctuation is either due to the tumor infiltration, reflected by the high Ki-67 index, or some paper also produce regression after chemotherapy. But bear in mind, our patient didn't receive any treatment prior. I found out another paper saying that transient regression is possible if patient have corticosteroid usage during initial screening. One paper reported as such regression after the screening of the adrenal lesion. So definitive diagnosis after high index of suspicion is image-guided biopsy. Treatment, the best still is chemotherapy. The recent paper, additional of the monoclonal antibody rituximab in the CHOP regimen showed a better complete response on 2 years overall survival. And adrenalectomy prior to chemo is effective and added no survival benefit. Okay, thank you.
Right, thank you, Dr. Amin, for such an interesting case. Okay, we learned a lot about this case, even though it's completely rare. I have never seen a lymphoma of the adrenal, but it still can happen. All right, thank you, Dr. Amin. I think next we go to Esmas. Esmas, can you